we continue with the next presentation. So everyone interested, please gather around us, around our stage that we created here at ESTRO for Raysearch webinars. We call ourselves an expertise-driven community, and no wonder we call ourselves like that, because we do have many experts working in our company, also collaborating together with us. And one of our partners that we do have a lot of work together, and we do make wonderful things happening, it's IBA. And IBA will join for the next presentation that will cover a topic on Proton Conformal Flash. And you know what? My colleague Eric is so much better in this topic, so I will allow him to introduce everyone who will present today. And let me just wish you all of us the amazing and interesting, curious next 30 minutes. So, Eric, the stage is yours.
Thank you, Marta. So, good afternoon. I'm Eric. I work at Raysearch headquarters in Stockholm, Sweden. And I will speak briefly about introduce conformal flash. And then second speaker is Julian Smets from IBA, who will speak about the machine adaptations to do conformal flash. And finally, we have Michelle Kim from the University of Pennsylvania that will speak about the road towards clinical trial with a human clinical trial with proton conformal flash that passes through a clinical trial with dogs and are now aiming for starting up the human clinical trial. So, by that, I switch over here. So I think most of you know what flash is about. It's about delivering dose at extremely high dose rate, and also at the same time doing everything you have to do within fractions of a second. Why do we do this? Well, there are preclinical evidence that high dose rate seems to conserve healthy tissue, while at the same time having the same effect on cancerous tissue. And of course, the whole game here is about maintaining dose to the target while preserving risk organs. And maybe flash opens up the therapeutic window a little bit. And finally, of course, the delivery happens fast. It's also has to happen with relatively few fractions. So it means that potentially you will also speed up delivery, and the patient has to come for treatment at fewer occasions. And the topic of today is conformal flash with protons. And we do that together with IBA and University of Pennsylvania. So this picture is from the flash workshop at UPenn a couple of weeks ago, and looking at Raystation treatment plans. So in Raystation we have support for conformal flash. We do that by inserting in Raystation's B model a 3D printed object, which looks like this. We call it a hedgehog because it looks like it has a solid body and spikes on the back. Raystation supports a planning process by which you start to create what we call a mother plan. The mother plan is in principle a standard IMPT plan, so you can optimize with robustness and any other optimization tricks you are used to. As a second step, we create an energy fluence fingerprint from the mother plan, and that fingerprint goes into a process to create the printing file for the 3D hedgehog. And then the final step is to re-optimize the flash plan with the hedgehog in the beam and one single energy layer. And this is the important thing here, that in the final plan you have a single energy layer, which is what enables fast delivery, of course. Well, yeah, here we have some more details about the hedgehog. So it's a 3D printed thing. We send it to a 3D print shop, and the result so far, this is a lot of efforts that have been on IBA side, but the result is that the 3D printing is reproducible, and it's also dosimetrically match what we compute in Raystation quite well. This is what Michelle will speak a little bit more about. I think this is my last slide. So this shows the first measurements with the 3D printed hedgehog. It's here on the couch at UPenn a year ago. And this is eye-based nozzle where we have a 3D printed hedgehog here. We have a bunch of rain-shifter plates and also a patient-specific aperture on top of that. So I think by that I hand over to Julian. Yes.
Thank you very much, Eric, for organizing this session on Conformal Flash and for the opportunity to showcase our developments at the University of Pennsylvania and the precious collaboration with Raysearch towards the first clinical trial. Our objective for these developments can be summarized in one sentence. We want the best of both worlds. We want to benefit from the radiobiological advantage of Flash while preserving the physical advantage of protons. And this means we want to increase the dose rate by 2 orders of magnitude, going from a typical 1 minute irradiation down to less than 1 second delivery, while preserving the unique feature of proton therapy, which is the shaping of the dose distribution at the distal, lateral, and proximal edges of the target volume. And in order to achieve this, we introduce new developments on the beam production system, on the beam management system, and on the quality assurance. And Michel will report on a canine trial at UPenn that already benefited from these developments. How does it work? Well, in Conformal Flash, the plan is delivered by scanning a pencil beam over a single energy layer, and beam shaping is achieved thanks to a dedicated snout that is mounted onto the nozzle. We deliver the maximum beam energy in order to achieve the maximum beam current in order to secure the flash effect. And then we add 3 accessories. First, range shifters adjust the distal range uniformly. Then the 3D printed patient-specific conformal crafts the energy modulation. And finally, an aperture is used to restore the sharpness of the lateral column. Now I will show you a video of Michel delivering the second fraction to the first canine patient at UPenn. I will show it in real time with no slow motion, and you will notice that it goes so fast it is almost impossible to notice while the irradiation is ongoing. Thank you.
All right, thank you so much. If I had known that video was going to be shown elsewhere, I may have paid attention to the camera a little bit, but that's okay. Thank you so much for being here, and I'm happy to report a little bit about how we did our canine trial and what our plans are for the human clinical trial, hopefully at the end of this year, early next year, with Conformal Flash. So our first trial was a canine head and neck cancer trial for dogs with spontaneous head and neck cancers, such as melanoma, squamous cell carcinoma, fibrosarcoma, or really anything that was defined in the head and neck. Subjects 1 through 3 were treated with shoot-through or transmission flash with a dose of 8 gray times 2 fractions. The second cohort, dogs 4 through 6, were treated with 12 gray, also with shoot-through, and with 2 fractions as well. And finally, our last cohort was treated with Conformal Flash with specific treatment plans generated for each of these dogs to a total dose of 24 gray and 2 fractions. So our workflow for Conformal Flash is actually very similar to sort of what we do already for SBRT. There's a simulation, treatment planning, all the way to QA, delivery, and post-treatment QA. And the whole process, if we do it efficiently, can take 14 days or less. So our first step is to do our proton simulation for this dog, standard CT simulation, but just making sure that we have the right immobilization available. All of these dogs are anesthetized. These are client dogs. These are people's pets, and they were brought in through the vet school, which is just down the street from us. We had a whole team to sort of help us with the immobilization and simulation for these dogs. The next step was having our physician, both our radiation oncologists from the vet school and from our department do target delineation. We wanted to make sure that we could see and delineate the target effectively, so that was the first step. Then we started doing the treatment planning process. After contouring, as Eric mentioned, we started to generate an IMPT-style mother plan in Raystation where we start to play with beam angles and see what was going to work best for this case. After the mother plan was sort of designed first, then we would do some optimization, both with spot spacing and the aperture, with the margins around the target being sort of what we can change. We would then look at the DVH, evaluate sort of the planning goals and the robustness of the mother plan, and then we would translate that into a conformal flash plan in Raystation. After that, we can do some subsequent optimization by changing our minimum and maximum allowable MU, and playing with some of the objectives as we needed to. And then finally, we would evaluate the flash plan mostly for dose, looking at the DVH, our planning goals, and again, our robustness. And then using a script, we can evaluate the dose rate that we're going to get from this plan using simulated timing structures from the beam scanning information. So for these 3 dogs that we treated with conformal flash, we treated to 24 gray physical dose. So if you include an RV factor, it was more closer to 26.4 gray. Our main objective was so that the CTV, 95% of it received the full fractionation, prescription dose. And organs at risk were varied, so a lot of these regions were very isolated, but there were some OARs that included the salivary gland, the tongue, brain, and some eyes. And for the first dog, we simulated this dog supine with the vac lock to make sure she didn't roll, and some head wedges to make sure we could stabilize the head. This is what our planning looked like. As you can see, we do utilize an aperture, and we can play with some of the spots and where the spots land on the aperture, what the margins are from the aperture, the beam's eye view to the target, and so forth. For this dog, we treated with single field, and that is one of the options we can do. Our third dog, we actually treated with 2 different fields for a more conformal plan. The first field was delivered on day 1, fraction 1, and the second field was delivered on day 2, fraction 2. We have our apertures. They have to come in at some point between the treatment planning and the actual delivery process, so we can't do QA without them, because these are also part of our QA processes to make sure that the aperture was milled correctly and our conformal energy modulator or ridge filter or hedgehog, whatever you want to call it, is also going to deliver the correct dose according to the plan. We can do some dose rate optimization sort of loosely using this system. What we've done is playing with different minimum and maximum MU, spot spacing and things like that, and it's iterative. Right now, we are not planning to optimize based on dose rate. I think that is a later sort of development as we start to learn more about what is effective when it comes to conformal flash treatment delivery. But with this sort of optimization that we do in an iterative sense, we can look at a simulated average dose rate across the whole field. That's total dose from the field divided by the total time. And we can look at the CTV and how much dose rate it's receiving. So we can go from something that started at 35 gray per second up to 40 gray per second and so forth. Again, looking at just the target volume, and you might wonder, what's the point of the dose rate with the target volume? It's still something that we still want to monitor, because anything around the target volume is going to be an OAR. With Raystation, we also get a really nice treatment system planning report. And really the point of this is to create a timeout process. We want to make sure that we have all of the accessories in place. They're correct. They're the right accessories. The patient-specific ones are also correct. They're also field-specific. So we want to make sure if we are delivering multiple fields, the right ones are loaded in, and we're in the process of creating a timeout procedure for our therapists as well. For quality assurance, we always do an accessory geometry check. We did, prior to our first couple of dogs, we did depth dose measurements with the specific treatment plans that were generated. We've done multiple depths doing 2D dose plane measurements and point dose measurements as well, making sure that our absolute dosimetry is also correct. Some of those results are seen here. This is an example of what we can do with the hedgehog, CTing it and comparing it with the DICOM generated sort of ideal version and making sure the elevation maps are in line and not too deviant. Our 2D dose plane measurements we've done with both the matrix PT at conventional dose rates, but with the same flash optics at our center, and also with the matrix air at ultra high dose rates. And we've compared them to the Raystation generated dose planes that were calculated onto a water phantom. And all of these were passing with great 3% 3 millimeter passing rates. We also looked at the sort of fall off in the distal end using the point dose measurements, and they all seemed to be in really good agreement, so we were feeling very good about this. We did this for all 3 of our dogs, all fields that were relevant. On the treatment day, we would do an accessory alignment, making sure that everything installed correctly, we have everything ready to go. We did a dry run with some verification of the log file to make sure that the treatment delivery was happening at a rate that was relevant to us. Once the dog would arrive into the clinic, they would go under anesthesia with the whole vet team, and then we would start image guidance. We did KVs and CVCTs. There's a timeout procedure, and finally flash delivery, which would take under a second. And then after treatment delivery, we would do sort of log file analysis to evaluate what was delivered and how it was delivered that day. Here's some pictures of our first dog that we treated with conformal flash. This was over 1.5 years ago. She had a very large tumor, as you saw from the contouring image. And she's over 1.5 years out with no actual tumor that's palpable and no major side effects. Some minor skin color, fur color changes. Nothing else other than that. She's doing very well. The owners are very happy. Imaging is done with, like I said, KVs. We can do an aperture check just to make sure that it's in the correct alignment. There's only one way to install it, which is great, but we want to make sure everything is looking good. We've also done cone beams. With the whole flash nozzle installed, we can still do cone beam CT, which is incredibly useful. And finally, for post-treatment QA, we can use open source software to look at sort of specific dose rates that are relevant to us, whether it's dose average dose rate, maximum percentile dose rate, et cetera. But just a general sense, our beam on time for these 2 fractions was under 300 milliseconds to deliver 12 gray, which meant that the dose rate, the field average dose rate, was about 40 gray per second for both of these fields. So our goal is to start a human clinical trial looking at recurrent head and neck cancer. This will be a dose of 40 gray total in 5 fractions. And the idea is that we will treatment plan having either 2 or 3 fields delivered, 1 field per day. And this will be dependent on the treatment plan, what the anatomy looks like for that patient and how it looks as we start to plan that. The workflow will be very similar to what we did for the dogs. Hopefully by the time we get to this point, we're a little bit more comfortable and we know exactly what kind of QA we will do, but all of our accessories still need to come in before delivery, before QA, and we will still do post-treatment QA as well. But just to start, give you an idea of what these plans look like. We did a planning study with Dr. Jennifer Zhu in our department. She's a medical physicist and faculty member. And we looked at various treatment plans with several patients, looking at VMAT Proton plans, conformal flash plans, and clinical Proton plans. And here are some representative images to show you what they look like. If you wanted to see the DVH comparisons, we did see that the planning studies show that tumor coverage and target sort of OIR planning constraints were met for all of these plans. The conformal flash plans were indeed very similar to the typical IMPT plans that we would deliver clinically. And our VMAT plans are shown as well in dashed lines. So one caveat being that we did choose the same angles that we did for the clinical Proton plan, but I think those are still going to be relevant for conformal flash. Just some final thoughts. I think flash proton therapy for head and neck tumors is feasible. We can achieve the relevant dose rates in a conformal way. We're ongoing, there's a lot of ongoing evaluation of sort of the tumor effects, biological effects, responses to normal tissue and things like that that are currently ongoing with mouse models, cell models, and canine models as well. We do want to continue to do further veterinary oncology studies as we move on to human trials. I think they're a really great model. They're closer to humans than mice are, and we can absolutely learn a lot from them, both from a workflow standpoint, but also biologically speaking as well. But in final thought is that we are ready for clinical trials. So in parallel with developments in dosimetry, planning, imaging, and technology, we are ready to go, and I'm very excited to get this started, hopefully in the next year. But this is an incredible team effort, and we would not be able to do it with all of these people. So I'm happy to be here representing all of them, and I'm also happy to take any questions. Thank you so much.
All right, so thank you, Michelle, so much. It's so exciting to see that, I'm sure. And we do have some time if anyone has a question to Michelle or to Eric or to Julianne. You big man can also join the stage back here. Don't worry, don't be shy. Do we have any questions?
Hi, thank you for that. That was a great talk. I might have missed that at the start, but it seemed like the shoot-through plans apply at lower average dose rate than the formal one. Is that correct?
I actually did not report the dose rates on the shoot-through plans, but they're also close to at least 40 grams per second for the field average dose rate. Now, I didn't report the average dose rate for individual organs or things like that, but they were at least on par. Yeah.
Thank you for the question. Any more? Right. Any final thoughts, Eric?
Yes.
Yeah.
So a final tip from me is that we have conformal flash planning in all our demonstrations. So if any of you would like to see how it really works from a planning point of view, please go and have a look. Thank you.